I have about 20 or 30 minutes to go over. Can you guys see this?
Yep.
Okay. Um, Focus of the joints. And first, this is not a focus. This is not a talk about this type of joint. This is a talk about, and actually, this. When I got this image, I was reminded of these excellent videos that were made by Luis and his reggae students. And I just wanted to give a quick shout out to them and just thank him for all the 4 years of hard work. And it's been it's an amazing experience to share with you guys. And I wish you the best of luck. Um, so, in terms of joints, we're going to cover four major joints, and we'll go through some cases and why you should use POCUS. We'll look at some of the evidence. And because this is a Zoom talk and we usually have a demo, in place of that, we'll have a walkthrough of a simplified approach to finding effusions on these joints. So which transducer should you use? Basically, it depends on how deep and big the joint is. If it's a bigger joint, then I usually use a curvilinear probe, which has a lower frequency. And because the ultrasound waves are sent out in a radial fashion, you'll also have like a broader range of view, which is really great for procedural uses. Now, if you have a smaller joint like elbows, ankles, wrists, etc., then this is where you probably would want to use a linear probe, which has a higher frequency, and you can get a lot of detail like muscle and even like little individual fibers of muscle. And yeah, if you are looking for tendons and ligaments, which is kind of outside the scope of this talk, you definitely want to use a linear transducer. So the first case is a real case from all of you. A 25-year-old man who has right shoulder pain, a deformity, although it was not that obvious because he was essentially ripped, and you can't really tell that much, but definitely holding it like he had potentially an anterior dislocation. And he experienced this actually on some sort of game show, and he slid down this mega slide, and instead of going through a hole, he hit a wall instead, and came in with this. And his exam is essentially that, like he's got abduction, internal rotation, and limited range of motion in the shoulder. A quick physical example, like especially for the juniors, if you can actually get them to do a quick internal external rotation while their shoulder is abducted or adducted, I mean, that means that it's probably not likely a dislocation, but more of an AC joint injury. So, but this guy, his shoulder wasn't like this. I mean, you couldn't really tell that it was flattened out like this. So, why should you use ultrasound for POCUS? Well, one, it's actually really great for the diagnosis of anterior dislocation. This is just a meta-analysis, and I highlighted the positive likelihood ratio. It is not a mistype of any sort. It's actually just a broad range, but essentially confidence intervals of like 8 to about infinity in terms of positive likelihood ratio. So it's really great, and it has a really great negative predictive value and negative likelihood ratio as well. And there are some concerns about missing fractures, and that's completely appropriate. This is definitely can pick up the fractures, but I know there's an editorial coming out from Annals by Dan Wangro and Vanessa Franco about that. But it is also great for pre-procedural injection, which I'll cover in terms of numbing up that joint so that you can avoid actual procedural sedation. And it's also great for when you actually think you might be done with the reduction to just confirm it before if you're using procedural sedation before turning off the anesthetic or sedation. So there are a couple of different ways you can do this. I like to use the posterior shoulder approach, and that just means that you're scanning from behind the shoulder itself. You have the indicator or your probe in an axial plane, and essentially you get this window right here where you have, because you're shooting from posterior to anterior, you have skin, you have subcutaneous fat right here, you have some deltoid. You can see like these fascial layers right here. And then underneath is the infraspinatus. Depends on how high or low you go, but you can either get infraspinatus or teres minor. And then this bony prominence right here is actually the glenoid rim. And this is the humeral head right here, and this is the labrum. And the infraspinatus does look kind of like a wave, and the posterior labrum looks somewhat like a sail. So in terms of how you do this, so in any like MSK ultrasound, you really want to have like start with like a familiar window, and typically that's the bony cortex of a long bone. You want to, when you're sliding up to the actual joint, you want to anticipate the anatomy. Typically, this means that you're going to see like flattening of that humeral cortex and transition into the neck and then the head of the joint itself. And while there's a lot of complicated structures around, you just want to focus on the actual treasure or your question, and that's whether this patient has a dislocation or an effusion, and don't get lost in the details. And if you do get lost, just go back to step one. And I find that this is really helpful. Put Cameron in here because I don't know, remind me of the pirate, I guess. So this is that walkthrough. So you're starting off at the humeral shaft right here, and basically you have this bony half circle or this hyperechoic half circle, and this is the humeral shaft. You're taking it in cross section, and as you slide up, you're going to hit the humeral neck right here, and this will look very, very weird. You won't really know what you're looking at. And this is similar to like if you're a rock climber, being in this space right here where you're just right underneath the ledge and you have no support whatsoever. You're basically hanging by your arms and you're off balance. So rock climbers know that you shouldn't be in this place. You should go above before you take a breather. So this is what you should be doing too when you're doing this ultrasound. And the reason is that when you're shooting the sound waves, because the sound waves are hitting the humeral neck or whatever neck it is, the waves are actually not perpendicular to the actual bony cortex, and as a result, the echoes that come back are much more diminished than as if they were perpendicular, and that's why you get this like non or indistinct view of the actual bony cortex. And then you go, what this tells you is that you just need to go up a little bit more, like a few millimeters. And when you do that, you'll find this joint space. And again, if you get lost, go back to the humeral cortex and start over. And so this is the humeral cortex, or the shaft, and then this is the neck. It becomes indistinct. And as you keep on going up a little bit more, you'll see a nice distinct humeral head right here. And this tells you that you're in the right space, and you can move a little bit more posterior and medial, and you'll get that. And to test that the joint is in place, you can actually have the patient internally and externally rotate, and you can see the contraction of the actual infraspinatus when you do that. So this is not a great handy effusion. Imagine that involves a lot of hugs, but this is actually a glenohumeral effusion, and you can see that there's fluid right here. This is using the curvilinear. You can see that there's a broader range of view. You can see the glenoid and the medial parts of the scapula as well. And then this is the using a linear probe where you don't have that field of view, but you actually have a lot more detail. You can see the infraspinatus a lot more clearly, as well as the deltoid right here. And these asterisks are effusions. And so this is what a shoulder dislocation looks like right here. This is, if you imagine that the humeral head is like a golf ball and the glenoid rim is the golf tee, if the golf ball is on top of the glenoid rim, that is not a dislocation, it's actually normal. But if it falls off like this, you can tell that this is a dislocation right here. And because you're pointing from posterior to anterior, this connotes that the humeral head is actually moved anteriorly, so this is an anterior dislocation. In terms of shoulder arthrocentesis, there are no landmark versus ultrasound guided studies, but we do know from the anesthesia and PM&R literature that shoulder injection with ultrasound is a lot better. It's better perceived by patients as well. And just kind of like a logical reason for this, you can go in blind and potentially inject like the deltoid infraspinatus, but why do that? You can actually visualize the joint on ultrasound, and you can go in directly to that. You can guide your needle directly into that. And we also know that, especially in older patients, that if you use intra-articular lidocaine, it's actually safer and faster than IV sedation, you know, due to like respiratory depression and hypotension. So something to consider in your elderly patients. So in terms of shoulder arthrocentesis, this is a picture that I got from Highland, and there are some faux pas here. So first, you'd want to sterilely prep the area. And you also want to have a sterile probe cover, gloves, and use sterile gel. And this is a 5 cc syringe. So you actually need like a 30-60 cc syringe because you actually, the shoulder joint as well as the hip joint, that can tolerate a lot of anesthetic. And typically you want to inject about 20 or 30 cc's of lidocaine. And if you're in the right space, if you see the needle tip in the actual space, you shouldn't really have any pressure when you inject. And because it takes about 15 minutes to kick in, you can actually go and see another patient while waiting for this to work. And it does work, even on quote unquote hunky arms. I'll let you talk to Dr. Brennan about that case. And this is a video of that. So you can see the needle coming in. This is the humeral head, the glenoid here, this is scapula. And you'll note that infraspinatus is actually pulled anteriorly too, along with the humeral head. And you'll see the needle going in right here. And when you inject, there are always little tiny micro bubbles. And that tells you when you inject right there that you're in the right space. Momentarily, there was a little bit of injection into the infraspinatus, but most of it went in here. And that's how you do that. So this is case 2. Case 2 is an 8-year-old boy who comes in. He loses his balance, falls off his bike, and his exam is pretty unremarkable. He actually has no deformity. He's got a little tenderness to his distal humerus, but essentially a pretty benign exam. You're wondering if you should do an X-ray. The kid looks like he's a little anxious, but mom wants something done. So what can you do? Well, first, you don't need POCUS for this. You don't need POCUS for like a supracondylar fracture like here that's displaced. Any obvious fractures on an X-ray. This is a posterior elbow dislocation. And this is an olecranon bursitis. It'll feel fleshy and bumpy right here. And so you really don't need ultrasound to do this. These are actually physical diagnoses. But if you have if you're worried that there might be like an occult fracture or a non-displaced fracture, typically you want to do an X-ray, and you're looking for this posterior fat pad sign, which is this essentially distension of the elbow joint and lifting off of the fat pad right here. And this is, pretty good in terms of if you get a good lateral X-ray of the elbow. But is there something better? And this is where, this is me usually on shift when someone poses a case like this. Get really excited, and I have this probably goofy look on me. And if it's a junior and I ask, like, I wish there was something that could help you see inside the body, what's this magical device? Juniors might be like this, especially interns. And if you're a senior and you've heard this over and over again, this is usually your common reaction. And if you're intrepid enough to say CT, this is the usual response that you'll get. Try again, fail better. And I can continue to entertain this. I'm just trying to read this comment. Oh, thank you. So basically, why are we doing POCUS for elbows? Well, this is a pediatric study, pediatric emergency physicians at Mount Sinai. And what it shows is that it's actually a little bit better than your lateral X-ray in terms of looking for effusion. High sensitivity, good negative predictive value, and good negative likelihood ratio. And what's more important is that these were novice Penn fellows and physicians with really little ultrasonic experience, and they were able to get this pretty well. Like, there's significant agreement between experts and novices after like 5 studies. So it gives you an idea of how easy it is to do. This is a related study. It shows that it's actually takes about 3 minutes versus an X-ray. Remember that it's not only the X-ray, but the interpretation. And it was 20 times faster. So it's a great, highly sensitive study, and it is quick to do. So you can get your kids home and resting with their parents. So how do you do this POCUS elbow ultrasound? Again, start with the familiar, work your way up, anticipate the anatomy, and focus on the treasure itself. And then if you are lost, go back to the original window. So in this case, you're starting with a posterior elbow ultrasound, and you want the probe right at the posterior humeral cortex, and it'll look like this. Again, this hyperechoic arc right here. And you'll notice that there's triceps on top as well. And as you slide distally towards the elbow itself, you'll see that the humeral cortex will actually flatten out and it'll start to actually divot in or invaginate a little bit. And this is the olecranon fossa. You'll see two little prominences right here. This is the medial and lateral condyles. And at this point, you can find that posterior fat pad, which looks like, essentially like a mixed echoic layer that looks like, I don't know, like a mouth or a tongue. And if you draw an imaginary line through the condyles, that fat pad should be underneath that. And that tells you that that's normal, that there's no elevated fat pad. And again, if you get lost, go back to the humeral cortex. So this is how you do that. And see how it starts to flatten out, starts to invaginate the humeral cortex. And then you have that fat pad right there. And if you draw a line through here, you'll note that the fat pad is underneath that intercondylar line. You can get a long axis window as well. And sometimes people prefer this. And when you rotate your probe, you're pointing towards the shoulder itself. And so this tells you that this is towards the shoulder, this is towards the elbow, and you'll see the triceps in long axis. You'll see those long fibers. And this is that posterior fat pad right here. So this is a long axis of the elbow, triceps on top. This is the proximal or distal humerus. This is that olecranon fossa, a condyle, and this is that fat pad right here. You'll notice that at the distal portion, a little bit of the fat pad rises above, but that's okay. In terms of elbow arthrocentesis, this is kind of like your traditional window right here. By the way, this is no one has studied elbow arthrocentesis ultrasound guided versus traditional. But again, in terms of procedurals or procedures in themselves, we know that if you can visualize it, it tends to be safer. So with the same rationale, you think about doing elbow ultrasound or elbow arthrocentesis using ultrasound. This is your traditional triangle with the lateral epicondyle, radial head, olecranon process. With the elbow ultrasound guided arthrocentesis, you're a little bit more medial and posterior, and theoretically you should avoid some of the motor branches of the radial nerve, which will innervate at the lateral epicondyle, the muscles there. And this is what you're aiming for. So the needle will go from the lateral to medial, and you can see it going into this elevated fat pad with fluid right here. And so you can do your aspiration at this point. Okay, case 3 is a 67-year-old woman with diabetes, and she presents with atraumatic or non-traumatic hip pain for about 2 weeks. She's got a relatively normal otherwise exam. There's no deformity of the hip. She's afebrile, etc. But she does have some limited passive and active range of motion of the hip itself. And so you do an x-ray, which most people do first, and there are no fractures. In terms of picking up effusions, it's pretty poor, anywhere from like 15 to 50%. So, if they have more hip pain, you're doing a CT and MRI, and definitely that higher sensitivity, especially MRI, that's essentially the gold standard. But it takes time. All of you will probably take like 4 to 8 hours for the MRI if you do that, and involves some radiation, IV contrast, etc. Here, if you do diagnose an effusion, that's where then you have to actually call the consultant, usually IR or orthopedics, and wait for them to come in if they're not in house. And you might be doing other things, you might be seeing other patients, but essentially the patient's waiting a long time to get this done. And every incremental step is an extra cost. And if there's additional testing, there's radiation, which is also a concern if you have a pediatric patient. So this is why you should actually think about using POCUS for hip, because First of all, like radiologists, they've understood this for quite some time. There's seminal studies from 30 years ago that show that radiologists perform ultrasound of the hip is similar in sensitivity to MRI and CT. And by the way, these are QR codes that link to these studies. And recently, about 10 years ago, actually, there was an PZM study that looked at hip arthrocentesis and actually hip ultrasound to evaluate for effusion. And you can see that there's pretty good numbers. In those with higher confidence, I guess experts and people with more experience, it was you had better characteristics. And about a year and a half ago, we actually had another study involving a 3D hip model that we made. And we had about 24 Harbor and all of you UCLA residents. And you could see that this is a pre-intervention, pre-education, pre-training. And we had a number of steps that we outlined. And this is post-training. You can see that it's a relatively easy procedure to do. This is that 3D printed hip model, which involved like not only 2 sites or 3 sites, Harvard, UCLA, all of you, and Reagan, but also several different departments, anatomy, radiology, as well as EM. And this is how you do the POCUS of the hip joint. Again, start with the familiar. You're going to find that femoral cortex right here, that nice femoral shaft. And as you go up, you're going to find, let me see. Okay, yes, Stephen. I'm almost done. You're going to find that intertrochanteric line. So this is the greater troch, the lesser troch. And as you go here, you'll see a flattening and almost like an extension of the femoral cortex. And that's your cue actually to actually rotate the probe towards the umbilicus like this. And at that point, you're going to get the long axis of the femoral neck and the femoral head. And you'll get this view right here. And what you're looking for is, and this is acetabulum, femoral head, femoral neck. You're looking at this anterior recess of the femoral head and neck, and you're measuring this distance right here. Normally, especially in younger patients, you'll have cartilage right here. So that can be a false positive. So typically you want to measure at least 5 to 8 millimeters of space, like an anechoic space right here. And that will tell you that there's a hip effusion. Or if you're not sure, you can look at the contralateral hip, the asymptomatic hip, and if there's a greater than 2 millimeter difference, then. And again, if you get lost, go back to the cortex and start over. So this is that maneuver right there. You're going to rotate the umbilicus, and oops. Geez, sorry guys. Okay, so this is that femoral cortex. It starts to flatten out. Then you rotate, and you get this right here. This is actually, I did this on myself yesterday on shift. And you can see that there's articular cartilage at the actual femoral head right here. And so I don't have an effusion. This is Rafi Salabian. He is one of our MSK radiologists doing a hip arthrocentesis on ultrasound. And just kind of like his commentary. So he's going in long axis or in plane approach. The needle will come in from the distal femur area. And this is the target right here. And you can see that the entire width of the needle. And at this window right here, you're pretty lateral to the femoral vessels, so you shouldn't have to worry about that. But in an in-plane approach, you should always visualize the needle. And if you don't, then you should really obtain that plane first. So here we go. And we are almost in that space. Right there, we are in the space. Right there. And at that point, you can do your arthrocentesis or aspiration. So the last case is a 33-year-old woman with knee pain for about 3 days. And again, pretty benign exam except for limited range of motion. And you're worried about infusion. So first, there are different bursae in the knee joint itself. And the superficial ones, the prepatellar bursae and the infrapatellar bursae that are subcutaneous, those you don't really need ultrasound because they're pretty obvious. You can palpate them. They'll feel fluctuant. This is a prepatellar bursitis right here. But in terms of ultrasound, you really need to worry about this actual intra-articular space right here and this large joint capsule here. And the problem with X-rays is that, again, the sensitivity is not that great. It's about 80%. If you do cross-stable lateral, where the beam is actually lateral to the knee itself, and the patient is supine, so you can have a layering of the lipohemorrhosis, that increases the sensitivity a little bit more, but again, not that great. Whereas, again, with ultrasound, it is pretty similar to CT in terms of looking for effusion. Some tricks, start with the familiar, look for the femur. This time you're going to have a sagittal or long axis view of the femur itself. And you want the knee flex about 30 degrees, and that tends to draw the patellar a little bit more inferiorly, and it pushes that joint capsule a little bit more superficially and superiorly, so you can actually detect effusion better. And basically what you're looking for is you're looking for this quadriceps tendon, and it will attach on the patella right here. Patella has this nice hypercoic arc or cortex with shadowing deep to that. And once you see that, the next thing that you look for is actually two fat pads. There's a quadriceps fat pad right here, which looks like kind of like a guitar pick or a triangle. And then this is a little bit more of an indistinct fat pad right here. This is the prefemoral fat pad. And in between, you should look for a widening of the space right here. This is normal. There's a little bit of fluid, but essentially normal. This is another ultrasound with a knee effusion right here. And the suprapatellar recess is the most sensitive part in terms of looking for a knee effusion. And again, if you get lost, go back to that femur and start over, find that patellar quadriceps tendon, and then find those fat pads again. So this is myself again on shift yesterday because I realized I didn't have like a good video of that. And basically, you can see that this is my femur, my femoral head right here. This is my articular cartilage. This is quadriceps fat pad. My prefemoral fat pad is over here, and I don't really have an effusion. And this is knee arthrocentesis. I don't have a video of that because I hardly use this for actual arthrocentesis, at least real-time guidance. I find the biggest pocket of fluid, whether it's lateral, medial, inferior, or superior to the patella, and that's where I go in with my needle. But this is a video of Dr. Sticknick from, I think, somewhere in New Jersey. He's a PMNR person, and he has a great video on YouTube that I copied. And so, yeah, basically you just find the biggest pocket, and then you prep, and you can go in without ultrasound guidance. That is it. Thank you again for I guess your attention. Let me open it up to questions right now.